Hello everyone. In this session, I'm going to talk about carcinoma of the esophagus. Previous year NEET as well as All India PG MCQs. We'll discuss with along with the MCQs. Okay, we'll start with the first question. Barium swallow findings in carcinoma of the esophagus are all except. Options are A. Rat tail deformity, B. Pencil tip appearance, C. Apple core appearance, and D. Filling defect. Okay, so answer for this question is that is B, that is pencil tip appearance. Okay, so let us first discuss about carcinoma of the esophagus. In carcinoma of the esophagus, what is the barium swallow findings? So what is barium swallow? Barium swallow is nothing but injection of the barium into that after the injection of the barium, you will take the a single picture you can able to visualize the esophagus, particularly mainly useful to diagnose the esophageal lesions. So it will map out the anatomy as well as the function anatomy. It will map out the anatomy as well as the function of the esophagus. So that is the main use of barium swallow. So the barium swallow is ideally indicated in all the patient, those they are presenting with the complaint of dysphagia. So that will be the first investigation of choice. Okay, so while after taking the barium swallow in carcinoma of the esophagus, the following findings will be there. Number one is the rat tail deformity. See, this rat tail deformity or rat tail sign is commonly seen in achalasia cardia. But here also you can get this rat tail deformity, which is nothing but there will be a filling defect. You can able to see the filling defect here, and this filling defect is irregular persistent filling defect. Okay, so you can see the filling defect here because of the growth here, because of the growth here. Okay, because of the growth here, and this is the proximal esophagus, and this is the distal part of the esophagus. You can able to see there is a luminal narrowing. Okay, so you can able to see a persistent irregular filling defect. So that is giving an appearance called rat tail deformity, but it's characteristically seen in cases of achalasia cardia. But here also you can get this finding. The next finding is apple core appearance, which is nothing but you can see that the apple core appearance also is very characteristically seen in colonic lesion. But here also you can get this one. What will happen? Just nothing but if the peripheral part of the apple is taken away, only the center core of the apple will be there. So that is called apple core appearance. Okay, so this, which is nothing but the growth will be there. This is the growth, and there will be a lumen will be there. So luminal narrowing is there. This gives an appearance called apple core appearance. So you will have the rat tail deformity and apple core appearance, and the filling defect that's already discussed. These findings will be there, and apart from that, you can able to see here that is the dilatation, proximal dilatation of the esophagus. So that will be another finding. And if so, these are all findings of the barium swallow in carcinoma of the esophagus. Okay, next we are going to discuss about I want to just discuss another important finding, that is what is this pencil tip appearance. Okay, so there are finding you can get in achalasia cardia. Achalasia cardia is a benign condition where you will get some important finding. I'll write it here. Achalasia cardia. One important finding, that is the bird beak appearance. Already I told about the rat tail, and apart from that, you will get a bad bird beak appearance as well as the pencil tip appearance. So these findings is characteristically seen in case of achalasia cardia. Okay, next one. T staging of the esophagus is best done by. Okay, T staging of the esophagus is best done by. So options are EUS, CT, MRI, PET. The answer for this question is EUS. So what is EUS? EUS is nothing but endoscopic ultrasound. Okay, when you pass the endoscope, the tip of the endoscope is attached with an ultrasound probe. So it is attached with an ultrasound probe. So you can able to see the layers of the esophagus. Okay, like this. So a concertina effect you can able to see. So you can able to assess the layer by layer. Suppose a growth is present in the esophagus. Suppose a growth is present here. You can able to assess that exactly what is the T stage. Okay, that is the tumor size. So, endoscopic ultrasound has a major role in staging of the carcinoma of the esophagus, particularly T staging, as well as lymph node involvement. If there is surrounding area, there is a lymph node enlargement is there, you can assess the lymph node also. So, these two things best assessed by endoscopic ultrasound. Answer is endoscopic ultrasound. Okay, next one. Which of the following is the best indicator of survival in esophagus? So just watch carefully. Survival. That means what will happen post-operatively. So patient, whether you are doing surgery or not, most of the time if you are doing surgery, you can assess the survival rate. Okay, so best assessed by the answer for this question is TNM staging. Best assessed by TNM staging. Okay, so other options are resection of margin, histology, location, size of the tumor. But this is the one. This is just now I discussed about T and N. Same thing, which is the survival, that is a prognosis. The prognosis of the carcinoma of the esophagus. If you take prognosis, the carcinoma esophagus has got a poor prognosis. The reason is, okay, the presentation. Okay, whenever they are presenting with the symptoms, most of the time the presentation, the symptoms already discussed, that is dysphagia. Okay, dysphagia is the main symptom, and other symptoms because of the hoarseness of voice, because of the recurrent laryngeal palsy. These symptoms are there, then that will be a late presentation. Okay, so most of the time you will get a late presentation. That's why the poor prognosis is very poor in carcinoma of the esophagus. How the prognosis assessed? Number one, it can be assessed by the presence of depth of invasion of the tumor. Depth of invasion of the tumor, that is the T staging. And second one is the number of lymph node involvement. And number three is the location of the tumor. Location. Okay, so this location is very important. The tumor that are present in the near the cricopharynx, and or as well as tumor that are present near the OG junction, has got a good prognosis when comparing with thoracic tumor that are presenting in the thoracic esophagus. That means, it's in other words, I will tell you that the tumor that are present in upper one third and lower one third have got a good prognosis when comparing with the middle one third. Okay, so these are the three factors that is you can assess the survival rate. Okay, so the answer for this question is TNM staging. Okay, go to the next question. So this is the same TNM staging of the esophageal cancer. TIS, that is the in situ, is the high grade dysplasia, and T1, that is involvement of the lamina propria and submucosa, and T2 is involvement of muscularis propria, T3 is beyond the muscularis propria, and T4A is involvement of adjacent structures like pleura, pericardium, and diaphragm. Whereas T4B is involvement of adjacent structure like trachea, bone, and aorta. And if you take a N status, 1 to 2 nodes is N1, 3 to 6, N2, 7 or more it is N3. Okay, this is about the TNM staging of esophageal cancer. What is the most common complication of placing stent in carcinoma of the esophagus? Okay, this also I am going to discuss in the upcoming slides, but I will tell you the answer. Here the answer for this question is migration. Migration is the commonest complication. Okay, we will discuss in the next slide. commonest site of esophageal carcinoma is. Okay, so if you take worldwide, the commonest tumor is the squamous cell carcinoma. Whereas in Western countries, the commonest carcinoma is adenocarcinoma. Okay, adenocarcinoma. Okay, so the MCQ they asked worldwide, then that is a squamous cell carcinoma, and the Western countries, it is adenocarcinoma. And if you take as the difference between the squamous cell carcinoma and adenocarcinoma, the squamous cell carcinoma is commonly seen in cases of patient they are used to take tobacco and alcohol. So these are the common predisposing factors. Whereas in case of adenocarcinoma, the common predisposing factor is the obesity and GERD. Okay, so these two are the common risk factors in case of adenocarcinoma. And if you take the location, then squamous cell carcinoma, upper one third, upper two third is common. Whereas in case of adenocarcinoma, lower one third, okay, the lesion that are present in the lower one third is very commonly you can get in adenocarcinoma, upper one third. Then other differences between the squamous cell carcinoma and adenocarcinoma is the treatment aspect. The treatment aspect, if you take the treatment aspect, here the treatment most of the time squamous cell carcinoma will be treated non-surgical management like CT and RT. Whereas this you need an aggressive surgical approach, that is esophagectomy you can plan in case of lower one third adenocarcinoma. Okay, so overall, if you take that, the most common site of the carcinoma, overall, if you can take, that is, the answer for this question will be middle one third of the esophagus. Okay, so that is the commonest site for the esophageal malignancy worldwide as well as in India also. Okay, the esophageal carcinoma is adequately assessed by barium swallow endoscopy and endoscopy ultrasound. Okay, so answer for this question is barium swallow and endoscopy. Okay, I already told that barium swallow is the first investigation of choice. Any patient they are presenting with dysphagia, the first investigation of choice is the barium swallow. And endoscopy is the it's a diagnostic test. It's a diagnosis. If you want to confirm the diagnosis, then you have to plan endoscopy. So here the question is they have asked about adequately assessed. Adequately assessed. That means a combination of these two investigation you can use to assess the esophageal carcinoma. So the answer is barium swallow and endoscopy. Okay, next question. Best palliation in carcinoma of the esophagus. Best palliation. Okay, in carcinoma of the esophagus, the word palliation means the most of the patient carcinoma esophagus, they will be presenting with a complaint called dysphagia. Okay, so the palliation is you can treat the patient so that the patient can able to take the food properly without any complaints of dysphagia. That is the word palliation. So previous days and all, we used to do feeding gastrostomy and feeding duodenostomy for for the carcinoma of the esophagus. Nowadays, we are not doing that. Is not a palliation. Previously, what we thought, at least for the feeding purpose, we are putting the gastrostomy tube, and that is not the treatment for the palliation. And similarly, surgical bypass is an extensive surgery. Here, the surgical bypass also an extensive surgery. It causes more morbidity and mortality. That is also not a best palliation. The best palliation is to relieve the dysphagia. So that can be done by the endo process. That is using the stents. Okay, we are going to discuss the same one. Same one. This is the SEMS. That is nothing but self-expanding. Okay, self-expanding metallic stent. Self-expanding metallic stent. So this is called a SEMS. So this stent you can able to see two type of stent. One is called this is covered stent and another one is the uncovered stent. So this covered stent is usually it will be coated with either silicone or polyurethane. Okay, so the advantage of stents are there. Previously, we used to keep a plastic rigid tube like Souter tube, Souter tube. So, what before keeping the tube, what you have to do is you have to do the dilatation of the esophagus. So, you have to dilate the esophagus and then you have to keep the Souter tube, but it causes more morbidity as well as mortality. So nowadays we are not using this Souter tube. Instead of that, we are using the self-expanding metallic stent. But here there is no need of dilatation. There is no need of dilatation of the esophagus. So you can keep the stent directly. The stent also you can keep in a deflated state. That means in a compressed state. You once you insert into the esophagus. So consider this is the esophagus, and you got the tumor. You got the tumor. Okay, then you can insert the stent in a deflated state. Okay, like this. Once you keep the stent in that position, it will expand, self-expanding. It itself can expand and just compress, pressing over the esophageal wall as well as the growth. But the most common complication of the stent by keeping this stent is the migration, and that too it is particularly in cases where you are keeping at the cricopharynx or at the level of the OG junction. In this level, there is more chances to get the migration of the stent. This is one important, most common complication. And apart from that, you will get another complication that is called tumor tumor ingrowth. Since you are not removing the tumor, what will happen? The tumor will grow, and again the stent, the purpose of stent, that is purpose of stent is to keep the esophagus open. The patient can able to take the food properly. Here that because of the tumor overgrowth, ingrowth, so the stent will be collapsed. So how to overcome this tumor ingrowth? The only two things. One is to keep a new stent. Keep a new stent, or else you just do the tumor ablation. So these two types of treatment to overcome the tumor ingrowth. So these two are the common complication you will come across in the self-expanding metallic stent. Next question, the characteristic feature of lymph node involvement on endoscopic ultrasound in carcinoma are all except. Okay, so these are the features. Round contour, yes, round contour will be there. The borders, sharp borders, and size more than 1 centimeter, it also will be there. But here it is not hyperechogenic. You will get an hypoechogenic lesion. That is the poor echogenic lesion. That is a poor echogenic lesion. Okay, so the answer for this question is hyperechogenic. Okay, the endoscopic ultrasound I already discussed, that is it is going to assess the T stage as well as a lymph node. So lymph node, you can assess that what is the characteristic feature of the lymph node, that can be defined by endoscopic ultrasound. Okay, so here you can able to see the same picture. You can able to see this is the esophagus. You can see the esophagus. You can concert in a layers of esophagus. Okay, here you are able to see the lymph node. Okay, so description is round contour, short borders, poor echogenic, that is hypoechogenic, and the last one is size more than 1 centimeter. See what classification is for. Okay, this is a straightforward question. No need of any explanation. The answer is GE junction tumors. GE junction tumors. What is the CWAT classification? CWAT classification I already just now discussed, that is the GE gastroesophageal junction tumors. Okay, there are type 1. Type 1 is nothing but it is a distal esophageal malignancy. Okay, the malignancy that is present in the distal esophageal malignancy, and gradually it is extending into the OG junction, distal, or else the malignancy that is arising from the Barrett esophagus. These two are called type 1 lesion of the GE malignancy. And second one, type 2. Type 2 is a true, it is a true OG junction CA. That means exactly at the junction you will get a malignancy. That is a true OG junction CA type 2. Type 3 is where you will get a tumor in the subcordial. Okay, just below the cardia you will get the tumor subcordial. So these three are the three types of the C-word classification. Okay, what is the name of the surgery in the esophagus? Okay, the picture is given here. What is the name of the surgery? Here the answer for this question is, that is answer C, that is Ivor-Lewis operation. Okay, so we will discuss one by one. Okay, so this option A, that is transhiatal esophagectomy, is otherwise called Oringer. Oringer is the one he found out. Oringer transhiatal esophagectomy. Okay, it consists of two parts of surgery. So what you have to do, you do one first, you do one laparotomy. Okay, you do one laparotomy by midline vertical incision and try to dissect the esophagus, lower end of the esophagus and stomach, and then mobilize the stomach. Then you take the stomach, that is the gastric pull through. It is called as gastric pull through. Okay, I'll put another picture you can able to assess. Okay, so this is the lower end of the esophagus and stomach is there. Okay, so what you have to do, okay, so you try to do the dissection of this and this next question I'm going to discuss one. Okay, anyway, you are taking the stomach, and dividing the that is esophagectomy has to be done. The cut end of the esophagus will be there in the at the level of the upper one third. You take the stomach and you have to anastomose the stomach by putting another separate incision, that is a cervical incision. In the neck you have to do the anastomosis. So Oringer transhiatal esophagectomy is it's the commonest, most common esophageal surgery. Okay, most common surgery that is done for esophagectomy is the Oringer esophageal transhiatal esophagectomy. Two incision, one is laparotomy, another one is the cervical incision. Laparotomy mobilize the esophagus and mobilize the gastric pull through can be done, and through the posterior mediastinum you take the stomach and anastomose the cut end of the esophagus, that is called in through the cervical incision. And second procedure is Ivor-Lewis operation. What is this Ivor-Lewis operation? This is the answer. Here you can able to see there are two steps of surgeries are there. One is called first thoracotomy, and that too right thoracotomy. And second one you have to do the laparotomy. Okay, thoracotomy. This is ideally indicated in cases of the middle one third of the lesion. Middle one third ideally indicated in cases of middle one third of lesion. Two incision, one is a right thoracotomy. Here you can able to see in this picture there is incision, right thoracotomy, and this is the midline vertical incision. Here the same thing, you mobilize the esophagus completely and divide the esophagus and you try to do the anastomosis. These two incision you have to make. This is Ivor-Lewis operation. And the third surgery, this is McEwen surgery. McEwen procedure is nothing but it is a three steps. So here you have to use a thoracotomy, you have to use laparotomy, and you have to make a cervical incision also. You have to make a cervical incision. All the three incision, three approaches you have to use, that is called McEwen procedure. So by doing this, you will remove the esophagus en bloc. That's called en bloc esophagectomy. En bloc esophagectomy. That is the McEwen procedure. Okay, answer is here is the Ivor-Lewis operation. Okay, conduit in gastric pull through is based on conduit, that is nothing but a substitute for esophagus. Gastric pull through is based on what artery? Okay, so I will put in another picture here. Okay, this is the stomach. This is your stomach is there, and if you see the vascular supply, vascular supply. Okay, so Okay, so you got short gastric also that. Okay, what you have to do, you have to divide left gastric, you have to divide left gastroepiploic artery, and you have to divide the short gastric arteries. So three arteries you have to divide, and the remaining that you have to keep the right gastric and right gastroepiploic artery. So the blood supply is based on right gastric and right gastroepiploic artery. Okay, so this is the answer A, that is you have to take that right gastro, that to preserve the right gastric and right gastroepiploic artery. The remaining, that is the left gastric, left gastroepiploic and short gastric arteries, you have to divide and mobilize the stomach, that is a mobilize the stomach, pull through, take the stomach to the posterior mediastinum. So in which way you can take? So there are so many ways you can take the this gastric pull through can be done. The commonest and shortest route is the posterior mediastinum. Okay, this posterior mediastinum you can take it through the where the previous esophagus was there. After removal of that, you can mobilize and you can keep it there in the posterior mediastinum, and then you can do the anastomosis, and you can take through the anterior mediastinum also, that is in the retrosternal region, anterior mediastinum through the retrosternal region. You can take laterally also, that can be done by the lateral to the root of lung, lateral to that you can take it, or you can take pre-sternal, or that is subcutaneous. Okay, subcutaneous or pre-sternal region, and you can do the anastomosis, but the commonest and shortest route is the posterior mediastinum. So, you can take this and you can do the anastomosis. Okay, next question. What is the best substitute for esophagus? The best substitute is none other than stomach is the best substitute. But in some cases, you can use the jejunum. Indication is if there is a short segment you need, then you can use the jejunum as an alternative. Then in cases suppose there is some problems with the in the stomach, there is some benign disorders of stomach like peptic ulcer disease is there, in that case you can plan for the colon. So this colon, already stomach we discussed that it is based on right gastric and right gastroepiploic artery, but the colon is mainly, that is particularly left colon, it is based on the left colon you have to use, and it is based on the left colic artery, and you have to keep the loop in an isoperistaltic manner. Okay, that is very important, isoperistaltic manner. Okay, so this is another important one. So colon also you can use, jejunum also you can use, but the best substitute is the stomach. Okay, thank you, ma.